Good morning, Dr. Eric Osgood. I wanted to just make a quick follow up. That's the first time I've really been interviewed in a public forum about a medical condition, and I hope people got something out of it. I really want to make sure I don't freak people out and provide the appropriate perspective and leave people with an educational takeaway without causing people to go around being more concerned and stressed. And just to tie on a little bit more to sort of a productive way that you can take something away from the conversation around what we call venous thromboembolism, blood clotting, and what we call thrombophilia, meaning a tendency to form blood clots. Uh, if you are a young person, it is exceedingly unlikely that you are experiencing a blood clot, and as we age, that becomes more common. And so those numbers, 1 to 2 per thousand patient years I mentioned, that's all comers, and it does skew more heavily toward the older population. And when people do experience blood clots at a younger age, it is more likely that it's associated with either an inherited or acquired disorder of coagulation or clotting. And the things I mentioned about having been on a long flight or having a fracture and then subsequently experiencing a blood clot, that is what we call a provoked blood clot or a provoked venous thromboembolism or a provoked deep vein thrombus, versus people who have them spontaneously, where you really can't attribute it to a prolonged period of immobilization or a surgery or a fracture, where we would call those unprovoked blood clots, which, particularly in younger populations, raise our antennae that there are more likely underlying causes of thrombophilia or hypercoagulability, a unusual or I should say abnormal tendency to want to form clots, and that is managed differently than when it is provoked and can be attributed to a particular insult or injury or provoking factor. And so that's sort of the key difference. And so when we start to worry about these genetic or inherited or acquired disorders of thrombophilia, is when, yes, young age, unprovoked, and then clots in abnormal places where you don't typically see them. As I mentioned, the leg and sometimes the upper extremity, the deep veins are common. When you see them in abnormal, unusual places, such as what we call the mesenteric circulation inside the abdomen, or sometimes in other less common parts of the vasculature, when you see clots there, that raises our antennae that, hey, there's probably some genetic, hereditary, or maybe acquired cause of hypercoagulability or thrombophilia. And so, what do we, what can you do to prevent it? Well, stay active. If you are on a long flight, make sure you're getting up and walking around the cabin. Make sure if you're less active, try to use compression stockings. But yeah, try to move along. We talked about stress. Stress hormones are really bad for any medical condition, and so it's always a good idea, whether it's meditation, yoga, tai chi, anything you can do, enjoying in recreational activities, going for walks. All of those things will reduce likelihood of sort of all-cause morbidity, really, and mortality. Um, Smoking cessation is really important, particularly in females who are using hormonal contraception. You really don't want to be smoking because that massively increases the likelihood of experiencing a blood clot. When it comes to genetic testing, there is really no broad scientific consensus around that. There's a lot of complexity within that because there's questions about how high of a yield would it be if we went around testing everybody for genetic disorders. In a lot of these genetic disorders, there's still an overwhelming likelihood you won't form a blood clot until you get to a much older age. And if you do, does it really change the treatment? You have to be put on blood thinners at that point. And if we just ran around, empirically putting people on blood thinners just because they had these genetic disorders and had not yet had a blood clot, the main side effect of these medications is causing bleeding, and the number one rule in medical ethics is do no harm. And so there's issues there too. Maybe if somebody with dual disorders or really serious combinations of thrombophilia, we would maybe consider something else. But generally speaking, there's really no broad consensus around this, and so there's no right or wrong answer. Different medical societies and opinion makers will, speak differently. The cost of genetic testing is coming down, and there are ways that people who want it and have family histories can get access to genetic testing. And if you do have family histories that are concerning, that's something you should always speak to your physician about. Now, what happens if you do go to present for medical care to, say, an emergency room because you think you may have a blood clot, let's say, in your leg? You would likely get a test called an ultrasound, a Doppler ultrasound of your leg, which is non-invasive and doesn't involve any radiation. And they put some ultrasound gel on, and they look, and they will be able to see it. If there's a concern that there may be a blood clot in the lung, which we call a pulmonary embolism, or PE, and these I mentioned some symptoms about chest pain, shortness of breath, elevated heart rate, sometimes low-grade fevers, coughing up blood streak, sputum, but PEs can be tricky and present in other ways, and so depending on the doctor that you see in the emergency room and their clinical suspicion, they may start out with a simple blood test, which is non-specific but highly sensitive, meaning it's good at ruling them out. And so if your test called your D dimer comes back within normal limits, it's very unlikely you're having a major blood clot. If it comes back elevated, that might not mean anything, but in combination with having a suspicion of a clot, they will send you usually for a test called a CT angiogram, which is a CAT scan. They give you IV contrast. If for some reason you can't tolerate radio contrast, or you have issues with your kidneys, there's another test called a ventilation perfusion scan that they can do, and they can ultimately identify defects in the filling in the lung circulation and make that diagnosis. Then what happens? It's interesting, we've come a long way. If you go back, way back, I mean, I'm talking back in the day, like back when 50 Cent was still cool. If you got a clot, even in your leg, remember, I'm a hospital doctor. You were coming to see me. The emergency room doctor was calling me. I was coming down to admit you, put you in the hospital. We'd have to put you on a continuous drip of medication that you would be on in the hospital probably for about 5 days. And then we'd be starting you on a medication at night that you take by mouth, and it takes about 72 hours for that to reach therapeutic levels. We then have to overlap it with the drip, and then at that time you could go home on that medication, which you take nightly. You have to watch what you eat because there's food-drug interactions, and you have to get your levels measured in an outpatient lab every so often. Nowadays, we have these improved treatments where if you have a clot in your leg, sometimes the emergency room doctors are not as comfortable treating that. They may still call me, but I'm going to come down, I'm going to give you a pill, and you get to go home. And you don't have to get any labs measured, and it's, things have come a long way. If you have a clot that has gone to your lungs, if it's really minor and you're not experiencing any signs of instability, sometimes you can go home. Usually, we'll keep you in the hospital for an overnight, just to make sure you respond to treatment, and then you go home and you take this medication. If it's provoked, meaning we can clearly attribute it to a provoking factor like a fracture or a prolonged period of immobility, usually around 6 months of treatment, and then it can be stopped. When it's unprovoked, or maybe it's recurrent or in an unusual location, it's extensive, large, at that point in time, in the future, you may be referred for further testing for what we call thrombophilia, to work you up for any underlying causes, and that may or may not result in either lifetime blood thinner therapy, or a longer duration of therapy. Again, the main side effect of these medications is bleeding, and in people who do have bleeding, those medications may have to be stopped, and then that source of bleeding may have to be addressed. In people who cannot tolerate being on blood thinners because they've had a bleed, hemorrhage, or they're at risk for hemorrhage, maybe somebody who has issues with balance and falls, we don't want someone to hit their head when they're on blood thinners. There's a procedure that's called a filter, an inferior vena cava filter, where they can actually go in through interventional radiology and place a filter device in that main vein, the inferior vena cava, which goes up to the heart from the lower extremities. And that way, if you do form clots that dislodge, it protects your heart and your lungs and will save your life. So that's another possibility. In severe cases, sometimes we have to use more drastic measures to sometimes mechanically remove clots from the lungs, but those are much, much more uncommon in serious cases. So good news is, if you have this condition, you address it quickly, you get medical attention, you make the diagnosis, we can take care of it, and the likelihood is that you will do okay. And I really appreciate the opportunity to get to talk about this topic, and hope everyone has a great week, and rest in power, Michael, and peace.